right. So thank you everyone for joining. And this session is about the future of precision medicine with AI. And so I had a good conversation earlier with our esteemed panelists, and it's a great honor to be here with such a panelist. So let me, brief introduction. Professor Gopinath Padmashri, Director of RL Jalapa Institute of Oncology and President-elect Indian Society of Oncology. We have also Dr. Gagan Prakash, Chief on Urologic Oncology, Professor, Department of Surgical Oncology, Tata Memorial Center, Mumbai. Dr. Hamanth Vudayaraju, Director of Surgical Oncology, Minimal Access Oncosurgery and Robotic Surgeon, Yashoda Hospitals, Securderabad. Okay. And Mr. Srinivas Rao Mahankali, former CEO, T-Hub Innovation Ecosystem Builder and Startup Mentor. And Ms. Manisha Sabu, Head, Infosys Foundations. So 3 surgeons, a CEO of Innovation Ecosystem Builder, and Manisha Sabu of Infosys Foundation. And let's start actually, and then this is going to be a shorter panel. I guess it's the end of the day for all of us, but the topic is as important as it gets, which is the future of precision medicine and what the implication is. So perhaps I can start with you, Professor Gopinath. So as a legendary figure in the Indian oncology, and you've seen, I guess, the entire progression of technology, and we discussed it earlier today as well. Perhaps if you can share your perspective about the changes you've seen and what are the implications and what's the future based on that from this multi-generation kind of perspective.
We are listening since morning that what is the change AI has brought in. We discussed it in the previous sessions. The patient herself has mentioned it, that what is the change she's trying to do with the existing government policies. Education is an important aspect of the whole scenario. We discussed it in the morning. We know that a lot of changes have been taken place in our education system and new policies have been made. Today we are talking about AI in health and disease. And today morning also we raised this question, should we change the curriculum models because AI has been come into the picture? And nobody should feel over the years that any new thing comes, the old thing will disappear. It should be complementary to each other, and then we should take it forward and utilize it to the larger aspect, society at large, how it is going to benefit us from the thing. Being in oncology profession, we are looking at the preventive aspect of it, diagnostic aspect of it, detections, therapeutic aspect of it, and as you mentioned by Manish Sharma, the wellness, we can use it for the long-term rehabilitation of the patient and well-being and preventive process. That is how we are trying to look at AI as an entity, and some of the things, 30 to 40% has been implemented. Remaining, we have to do it in a sustainable model, not in an immediate one shot you go. As you said since morning, what is to be done now is more important rather than talking about the future. If you don't do the things well, we may not look at the brighter future.
So if I can perhaps jump actually to Dr. Hemanth. You're actually third generation, academic generation from professor, so it would be interesting to hear your perspective. Is it similar, different? Any point of views on the past, present, and future of AI for precision health on the surgical side?
Thanks. So I was just looking up what is common between a surgeon, AI, and what's uncommon between, what's the difference between how AI works and how surgeon works, what's common and what's not common. So when it comes to learning, the way we learn, I think, is very difficult, very different from the way AI models learn. So going from Sir's generation to our generation, the technology transfer which is there, I think is going to get better with time. So there are, I don't know if most people agree here, that we classify surgeons based on belief systems as this surgeon's hand is safer, that surgeon's hand is, a better surgeon is probably a well-trained surgeon, somebody who's learned more quickly than the others. So I think that is going to get even with the AI coming in. So AI, I feel, is going to make an impact in surgical technology transfer, if I can call it, between the generations, rather than AI becoming a surgeon itself. I think that I see it happening shortly. Probably that will be the first change which is going to happen. So I'm going to learn better from my teachers, and the next generation is going to learn better on par with me or even quicker than me. I think that's a place where AI is going to come.
I'm sure we're going to touch on that later on, but keen to hear also the perspective of Dr. Gagan Prakash on that. Another surgeon, so if anybody needs surgery today, we have here 3 surgeons on stage.
Yeah, you see, so let me just take it from where Dr. Hemant left it. And how I see it is that, if we had to take the analogy of all the Google products that we so commonly use, I don't see that day far away that we would have a navigation system, we would have a Google Maps when the surgeon is on the robotic console. We would have the ability to predict that this is a vessel, this is a ureter, this is a tricky zone, over here the planes are not good, avoid it. The navigation could include a Google alert, something like that, where we say that, okay, these areas are prone for complications. And that is what Dr. Hemant meant by, reducing the learning curve. So essentially, something which you would have gained by having a learning curve of 1,000 surgeries or 500 surgeries, you might be able to truncate it because you have, a navigation and an intraoperative navigation system. Then there are a lot of things which are intraoperative decisions, So, there are times when we are stuck about a decision, whether we have to go ahead or no, whether we have to take a certain step or no. And normally, just as we might be stuck and, go on to Google search and make a decision, I'm sure there would be tools which would help us take those intraoperative decisions. A lot of times these decisions, we would take the help of our seniors or mentors, sometimes call them intraoperatively, and then take a call. And if there's a tool which can help us take those tricky decisions, we might have an idea about that this particular surgery, there is a possibility of, coming to at the crossroads. But if you are actually over there, then can some tool actually help you in taking that decision is another area that could be looked at. The whole education or the proctoring or the mentoring part is something which I see can be hugely transformed, especially because a lot of surgeries these days are performed minimally invasive, which means that whatever is seen to the surgeon is already in a digitalized form. You have a video for that. The intuitive surgicals that the pioneers in the robotic system, they have a system called the Intuitive Hub, where you can actually live transmit an ongoing surgery to any part of the world, and the receiver over there can either be a mentor or a student, and they can actually see what's happening in the surgery. If it's a mentor, they can point out that, hey, this is probably not the right zone, you could do this differently. So I think that, many of these things are going to transform. Your anatomy is going to be seen better. Your complication rates would probably hopefully be changing because, you're doing it better. So integration of all these aspects is going to be exciting, yeah.
There are many topics here that I would love to double click, but in the interest of time, let's keep it to later if we remain any time on that, and we had some good discussions ahead. I actually want to jump to the implication of the community, and Ms. Manisha Sabu. So the ultimate, and again, you're head of Infosys Foundation, and the ultimate criticism of precision medicine is that its hyper-personalized nature makes it economically elite. And overcoming this requires leveraging large-scale digital architecture, and strategic philanthropic interventions to lower delivery costs. Now, and I think Professor also touched on the question of how can we make it more available. So when you navigate the intersection of world-class corporate enterprise and massive social impact via the Infosys Foundation, as AI pushes precision medicine forward, how can major foundations and tech leaders collaborate to scale affordable, cloud-based AI diagnostic networks so that a patient in a rural or tier 2 setting has access to the exact same caliber of personalized care as someone in a major metro hospital?
Well, that was a long question, and if I have to give the complete answer for that, I'll require at least 2-3 hours because it's a deep subject. I'll try my best to shorten it and be precise. So, see, when it comes to the problem about last mile care, there are multiple issues, right, from infrastructure to availability of the healthcare workers to even ability to pay for the treatment. While everything requires attention, for now let's just look at what is the most important and which is the low-hanging fruit which we can work at. So as per the WHO report, almost 80 to 90% of the healthcare requirements are about primary care. And even this primary care is very difficult to get for a tier 2, tier 3 or the remote rural areas. So foundations or the charity organization, philanthropists and the tech organizations have a large role to support this last mile care and the solution is not doctors there. The solution is how do we empower the people who are in the peripheral services, could be ASHA workers or could be even sometimes a pharmacist, to prescribe or to give simple right medicine to the patient who comes to them. You will not believe that in India, the pharmacist is actually the first person who gives medicines. They don't go to doctors, they go to pharmacists and just say, give me something, I have a headache. So, how do we empower them? And that's where Infosys Foundation and LV Prasad Eye Institute have come together on the eye care part. This is just one example where we have created an application which any common person can use very simply, and it will tell whether they need to go to the specialist or there is no need to go to a specialist, and some things. Follow-up care, everything after that is taken care through that. So similarly, the precision can come through by using AI models. That's the kind of work that foundations, philanthropists, and tech organizations can do to make the healthcare available for the tier 2, tier 3 cities so that they get good quality, accessible, affordable.
Thank you. So talking about community and ecosystem, Mr. MSR, thank you. How can you share, so you have a lot of experience with working with ecosystems. If you identify what should we do in order to enable technology to unlock it so that we can actually have it more effective across ecosystems, what are the gaps, technological, operational, and others, that you see that we should be doing, and where are we right now, and where could we be heading?
Thank you. So just some quick numbers. So we have about 223,000 registered startups in India. Okay, approximately around 2,000 are in the healthcare, health tech space, right? Not 10, 1%. Okay. Now, out of these, there are 3 eminent doctors here, so I have to be careful about what I say, right? But probably out of the 2,200 registered, health tech startups, less than 50 to 60 actually have got solutions which have been deployed in hospitals. Okay, so you can start with that problem, right? And when you start to, let's say, peel the onion a little further, the gaps, and I have my colleague here, Rashmi, who runs a ecosystem, so I'm sure she'll echo what I'm going to say. Broadly, I think there are three big areas which need to be solved. The first is access to data. Right? How does a no-name startup get access to data other than, for example, knowing Dr. Gagan or knowing Dr. Hemant? It's done on a one-on-one personal basis, but is there something where a startup can go to an independent review board, what you call IRB, right, and get access to data? So I think that's the first gap which has to be fixed. The second, and I remember a couple of years ago, we had a team from the FDA come to T-Hub, and they talked about that they now have a digital center for AI. Okay, so the FDA approves solutions, vet solutions, etc. We don't have an equivalent in India today to fast track AI diagnostics, right? And I'm really talking about two bodies. One is something called CDSCO, and the other is the National Health Authority, right? So data is a problem, regulatory sandboxes are a problem, and the third, at the risk of, there must be some hospital administrators here, at the risk of getting a few of them quite angry at me, we don't have a process to procure. We are good at procuring equipment, but we are not good at procuring software, particularly if you try and link, say, if you're buying an AI diagnostic tool and you try and link it to some outcomes, clinical outcomes, I don't think we've figured out a model. So equivalent of what has been done, for example, in the B2B context from a SaaS perspective, we don't have that in healthcare, right? So these are the three big gaps from a startup perspective, right? Now, a few other things which, if you allow me for another minute to talk, there's also an issue with startups, right? So patient capital is a challenge in India. We don't have, capital which can fund long-term research of the type Google does. But having said that, if there are things the startup can do where you focus on delivering outcomes, right? Which could be, for example, how do you save cost? How do you reduce time, for example, or cost per quality or something like that? The chances are that you can get funded a little better. So there's a need for startups also to start thinking a little bit more about outcomes and not get too caught up in the science part, the science and the tech part, right? So broadly, three things from a regulator. I wish I could have asked Karuna Gopalji, I think she's left, the policy maker. Focus on how you can give more democratic access to data, make it not person dependent but system based. Second is make it easier by creating regulatory sandboxes to fast track trials and so on. And the third is work on better procurement processes.
Yeah, but, and I truly believe, by the way, that having the infrastructure for the community and for startups is major. By the way, platforms in general. I happen to be the one who started what is now known to be Google for Startup Accelerator, with the belief that we should actually help support startups. This has been, and it was great to see how actually a little mentorship and empowerment actually goes a long way. And by the way, congrats on the T-Hub here, which is a great platform for that, for startups. Similarly, that's why we're doing also the like of Medgema as a platform. One thing that I would encourage, and this notion of bringing data that you mentioned, I think is critical and something that we should all as a community look into, how to make data available, because how many startups do you say there are? 220,000?
2,200.
How many of them in the health space?
No, so out of the 223,000, about 1% are in health tech.
1%. That's a big number. So one thing to consider in order to really help build innovation on top of that is how indeed to bring the expertise. And what we've heard from our surgeons here is some aspirations of here are things that could be beneficial. So I'm sure this could be inspiring I'm sure there are companies looking into that, but I'm sure there's a lot of innovation also for startups that could actually build into that. And we discussed a little bit this notion of AI as identifying areas and for prioritizations that could, if we could just, the most limited resource that we have are really the experts, as we know, the expertise. We can take a few more minutes, and since we really made it a short session, we'll take a few minutes after the alert we're going to get briefly, but please, you want to make more comments on that?
I was just kind of emphasizing what MSR just mentioned. I think he's pointed out something that's very pertinent. He's in fact nailed it, you know. So what's happening is that despite apparently thinking that we've got really big data because of the sheer volumes that we have in the hospitals and all, the ones that actually get translated into some meaningful algorithms or being utilized by the startups to the point that they can be deployed in the hospitals, that is, you know, that really needs to go up. And I think the role of the regulatory authorities over here is huge. That pathway needs to be streamlined. In fact, Chinnababu has just stepped out, but my suggestion would be that for, you know, for the AI meeting 3.0 next year, I think there should be a strong representation from the policymakers and the regulators. There is also, I think, a bit of a notion that whether the whole deployment and building of the algorithm should be done within the country. I mean, I think there's a concern if the data can stay within India and we can build it. So, you know, there is one pathway where the data can be kind of transferred to another organization or another center, which has already validated in some other parts of the world, and the same can be replicated and validated for the Indian population and then deployed, which probably would be a faster route. The slower route would be that we construct, or we might have to maybe reverse engineer or, you know, construct the whole thing or our set of patients or our set of data, and then build the whole thing from the scratch. And that is, I think, something which is probably what the government or the authorities might be, I don't know if that's what they want to take it, which might be a longer route, but yeah, those are things to be considered as well.
See, we heard, see, the most important thing is the transfer of technology has to take place, which should be beneficial to the patient care or a public at large in all walks. So the most important thing in anything, we bring in the transfer of technology. Education is an important thing at all levels, all specialties. We should not differentiate between engineering, medicine, whatnot. There is a need, everybody has worked on it, transfer of technology through education, skill, and learning, which we are talking about, especially in AI phenomena. We build this with all the things available. We can make use of the people like Infosys Foundation and Azim Premji to give us a lot of money to do the education and spread the message. They have done it. They will come late. He is an end user. You are the money giver. So this is very important. If everybody joins hand and utilize the how to bring in education, then the transfer of technology becomes more easy. We have seen everybody presenting the data. Everybody has got an interest. As previous discussion took place, at the end of some years, is it possible to see the reality what we are discussing in implementation to the patient care in the form of prevention, diagnosis, any part of the disease process?
Yeah, I think education is an entirely different topic. I think it's actually a topic for tomorrow. Pete is going to talk about it in a panel. So I'm promoting Pete's panel for tomorrow to talk about education. Well, let's just have one last quick comment from everyone who would like to make any short comment, and then we can adjourn. Any final comments from anyone?
Yep. We have lots, in India we have, lots of people. We also have lots of data. So we have, so many people with diabetes, so many people with cancer. We can also become the data capital of the world as far as healthcare is concerned, provided we put in the right kind of IP protection frameworks and governance frameworks.
On the same note, the data in India or anywhere in the world is highly unstructured, especially when it comes to medical care, because there are different protocols, different ways of approaching a same problem. The same solution might lead you through, I mean, you have to go through different pathways to get to the same solution. So whose data are we basing our AI's learning on, I think is going to decide what the patient is going to get at the end of the day. That is a big worry.
I think if that video recording is fed into a system and looked at later on, there's going to be a trend seen at the end of it. I think the first version of this meeting, the second version, we've got the best of the minds from medicine, the best of the minds from tech. The gaps are essentially the processes and the regulatory, and that's what we should be focusing on.
Ms. Manisha, any last comments?
Yeah, everybody mentioned data, and when it comes to data, the thing which comes to my mind is responsible AI. It really makes me worried.
Okay. Last word from you, Professor?
Yeah, we look at the biology as a very important aspect in health and medical profession. Now we should look beyond biology, involve technology, and see how we can introduce the newer generation of AI, which will be beneficial to the public at large.
Wonderful. Thanks to the panelists. Just a quick thought on last comments. Obviously, responsible AI, making things in a responsible, safe way is paramount to everything that we do. I think Manish perhaps quoted one of our favorite sayings, that health moves at the speed of trust, and that's how we operate. Data is really fuel for AI. AI is the engine for the future. And importantly, unstructured data is not an obstacle, because AI can deal with unstructured data as well, very well. One thing I encourage everyone, all of us, to keep in mind that many of our limitations today are temporary, because AI is a tool that helps out also overcome that. So let's think into the future. Let's vision the world in which every surgeon can actually have AI helping them do the work even more effectively, and a world in which everyone can have those services from the community, and startups can actually have more innovations to actually accelerate all of that. And I'm sure there are going to be more conversations. Thanks to our panelists. Thank you very much to everybody this late hour.